Okay, good morning, Dr. Villa, Dr. Virus, and my dear colleagues. Today I will be sharing about MI management in ED lah. First of all, I will remind all of us about the spectrum of SCS. First thing, the patient will come with ischemic discomfort, and then we must think about SCS lah, and then usually we'll take a ECG for the patient, and we will see if there is a ST elevation or there is no ST elevation, and after that we will send the blood for the patient. We will see the cardiac markers, cardiac biomarkers, whether it is raised or not. If from the ECG there is no ST elevation and the cardiac biomarkers were normal, so the diagnosis will be unstable angina. But if there is no ST elevation but raised in cardiac biomarkers, so the diagnosis will be non-ST elevation myocardial infarction. And then if from the ECG we saw ST, so they were raised in cardiac biomarkers, so the diagnosis will be ST elevation myocardial infarction. And then the next thing, how do we diagnose SCS or MI? First of all, we will take a little bit of history from the patient. We will do physical examination, ECG, and cardiac biomarkers. So from the history, what we usually encounter for the SCS, usually the patient will come with a typical chest pain. The chest pain is usually retrosternal, central, or on the left chest lah. And the pain also may radiate to the jaw or to the upper limb. And the nature of the pain is usually crushing, pressing, or burning in nature. And the severity of the pain is variable from one person to another person. But we also have to be familiar with the atypical symptom, which is common in women, diabetics, or elderly patient. They might not come with a typical chest pain. They might be presenting with a deep dyspnea, or unexplained sweating, nausea, vomiting, or syncope. Also, they might come with a gastric discomfort. So,
okay. Alif, previous slide, please. Okay, everyone. The previous slides.
The previous slide, okay.
Kindly give weightage for these slides because you see, when we encountered IHD kan, ni lebih kepada orang yang berumur kan, common age, right? So you won't expect the typical presentation. So we really need to give emphasis, especially females, those post-menopausal age. Their presentation memang atypical sangat, especially datang dengan epigastric pain, rasa letih sangat, and then usually what will our common diagnosis, kita akan tulis GERD. Betul tak? Ataupun lethargic for investigation. This is a normal scenario where we tend to miss, ramai sangat, we tend to miss the non-STEMI in this group of patients, or unstable angina. So history in general, history comes 80% of the weightage when we are providing a diagnosis for any impression. Okay?
Okay. So the next thing we do after taking the history, we'll be doing the physical examination. The aim of our physical examination is to determine what is the possible cause of the patient's presentation, what is the precipitating cause, and what is the consequence of unstable angina and MI. So from our physical examination, we found the patient having a hypotension, respiratory crackers, or atrial or arrhythmias. So we have to think that this patient will carry a poor prognosis. And then what does the features in ECG that we could see if the patient have unstable angina or non-STEMI? They will be having dynamic ST changes. They will be having ST depression, which is more than 0.5 mn in 2 or more contiguous leads. 0.5 mm is about 1 liter square in the ECG lead. So the patient might also have T-wave inversion. And other ECG that we might miss, there is like the new onset of bundle branch block, arrhythmias, previous Q wave. However, a normal ECG does not exclude the diagnosis of unstable angina and non-STEMI. So, in order to not miss the diagnosis, we have to do serial ECGs so we could see the dynamic changes in the ST. So this is a few. Yes.
Sorry, Alif, back to the previous slides. Okay, you mentioned about the cardiac arrhythmia suggestive of unstable angina or non-STEMI, right? Contoh cardiac arrhythmia Alif encountered sepanjang kerja kat ED ni apanya?
Cardiac arrhythmia biasanya AF lah.
AF lah, most common lah. Very good. How about the SVT in a young age group? You nak cover dah ACS?
SVT in young age group? I cover juga.
Cover juga. Okay, how about the others? Kamal? Kamal? Tak ada pula. Usni ada Usni?
Oh, Farah.
Farah?
Hello, Doktor.
Yeah. How tadi Alif kata dia nak cover juga SVT in young age group. Dia nak cover untuk ACS. Generally, blanket rule kita nak cover ke?
Generally, sebab Doktor, I found macam ada satu case lah, macam young age juga SVT, tapi dia memang ada underlying congenital heart disease kan.
Okay, good.
So yang tu kita cover.
Okay. How about those with not known comorbid? A sudden onset of palpitation, ECG shows, cardiac monitor shows SVT. In young age, about 22 or 20, 18, 19?
Usually tak lah kot Doktor.
So blanket rule, bukan semua patient datang dengan arrhythmia kita nak cover. Especially you look at the age factor. Those who are young age, you tengok dulu ada tak precipitating factor yang lain. Contohnya, patient ada sepsis tak? Ataupun patient ada hyperthyroid tak? Ataupun patient ambil beta-2 agonist for the asthma. So it's common cause to develop SVT. Tapi kalau old age, anything above 50 and above it, additional with underlying IHD or pathological heart, yes, the weightage go for the ACS coverage. Okay, na? Okay, then how about PVC in young group?
PVC in young group.
Nampak kan kadang-kadang ada satu je abnormal QRS complex dalam dia punya ECG tu. Randomly distributed. Nak cover juga. Patient datang dengan pleuritic chest pain.
Kalau just only one PVC, no need to cover.
Okay, then you need to look for other source. Okay, the history of the pleuritic chest pain need to get in detail. Time onset, berapa lama dia tahan, precipitating factor, relieving factor. Lepas tu you have to serial ECG followed by apa? Tengok electrolyte imbalance ada ke tak ada nah. Okay, kenapa PVC ni penting sangat ya? What the PVC will lead to?
PVC ya. Arrhythmia. Okay, arrhythmia apa tu? Common. The most
flutter.
Ya?
Flutter, atrial flutter.
Flutter tu dari mana? PVC dari mana? Flutter tu daripada atrium. Betul tak?
Betul.
PVC tu daripada ventricle.
VT.
VT. PVC lebih daripada 2 and more, you need to be very cautious because it can prone to get for patient ventricular tachycardia.
Okay.
Okay, the next slide, proceed.
Okay. It's a few example of ST segment depression. It could be upsloping, downsloping, or in a horizontal lane. So there are few cardiac biomarkers. We usually send CK and a troponin I. But troponin I or troponin T are the recommended biomarkers to send as they are highly specific and sensitive compared to creatine kinase. And myoglobin and LDH are usually not very specific.
Okay, Nafis ada previous slide, Alif? Nafis? Nafis ada? Awak Housemen ni tak nak jawab ni. Nafis, are you there? Okay, tak apa. Dr. Vila nak tanya soalan. Okay, let's say I have a patient who presented with chest pain. Baru pukul 10 started. Patient presented to us at 11 AM. And ECG shows ST depression in anterolateral lead. Nak ambil cardiac marker yang mana ni? Which cardiac marker you all want to take?
Someone answered in the chat, Dr. Vila.
Oh, sorry, checkbook ya.
Ada.
Drop eye, Khairul Anwar. Okay, ada lagi answer? Yes, chest pain 10 o'clock presented to us at 11 o'clock. Okay, look at your mana ni, warna hijau ni. It started to reach the peak within the drop eye. Kita nak ambil CKMB. Anyone taker? Tak nak ambil CKMB? Kau nak ambil drop eye juga?
Depends on timing kan?
It depends on the time of patient presented. We advise drop eye best to take in the
Early to last 2 hours, as less 2 days.
Less than 2 days, fair enough. But as soon as early berapa tu? Kalau boleh kita practice 3 jam lepas dia dapat simptom. Nah, the first 1 hour you may not to able to detect the drop eye. Okay? So you may take, so katakanlah patient ni datang pada pukul 10 chest pain, datang pukul 11. You may repeat the drop eye, katakan hendak terambil pukul 11 tu. You want to see whether it's a true unstable angina ke tak ada, atau non-stemming, you can repeat the drop eye pukul berapa tu? 10, 11, 12, 12.
Pukul 12. After tahu.
You may repeat one more. Okay, let's say patient ada recent MI. Patient ada recent MI. Dia presented dengan chest pain lepas hari ke-13. What
CE ya.
CK, security kini.
Very good. Because drop eye dia memang akan turun, tapi taklah okay lah. Let's say day 7, dia takkan significantly turun lah. It memang it still will be in a high level. So you better to take CK to look for new recent reinfection. The ACS component there. Okay? Okay, next.
So this is the simplified risk stratification model. So how do we classify the patient into the low risk group or the high risk group? The patient with the low risk group, the criteria is like the patient have no angina in the past, no ongoing angina, and the ECG is normal, cardiac marker not raised, and normal age group. So we just treat this patient as outpatient with medical therapy, including aspirin, beta blocker, and GTN. For the high-risk patient, they might have recurrent chest pain, post-infarction, unstable angina, or you can usually see the dynamic ST changes, elevated cardiac biomarkers, and they might come with instability hemodynamically, with the depressed LV function, with low ejection fraction, or major arrhythmias. So for the patient, we have to aim for coronary angiography and revascularization. And the next thing I'll be talking about STEMI. How do we diagnose ST elevation MI? So in general, we have to look for ST elevation of more than 1 1 mm into contiguous leads. 1 mm is equal to 1 liter square lah in the ECG strip. Or
Small box, yeah?
if the
One small box.
one small
Yes,
box.
I was going, yeah.
One small box in the ECG strip. If there is like new onset of left bundle branch block in the rectal ECG, or if the patient came with a more than 30 minutes of ischemic type chest pain, you have to think about STEMI also lah. And the other thing is the raise in cardiac biomarkers. So there are 5 classification of MI. The type 1 is spontaneous MI due to the blockage coronary arterial thrombosis. Type 2 is MI secondary to hypoxia. And type 3 is MI that result to death when there is no cardiac biomarkers available. And type 4 AMI is MI related to PCI. And type 4B is MI related to stent thrombosis. And lastly, type 5 MI related to bypass surgery, KBH.
Okay, Alif,
Yes.
the previous slide, does all this MI requires thrombolytic agent? No, next time. Does all this MI requires thrombolytic agent?
Anemia tak perlu.
So anemia will fall to which group?
Yes.
Anemia will fall to which group?
Anemia, I think the type 2 MI.
Okay, what else MI can fall into type 2 MI? Siapa ni Mochi Hantaro ni? Mochi.
Imbalance between myocardial oxygen demand and
What else? Can I have an example for type 2 MI?
Pulmonary respiratory problem.
Pulmonary respiratory contohnya sayang. Okay, satu, severe anemia, kita tak boleh thrombolyze. Satu lagi. Pernah tengok dekat kita punya ni dekat tak pernah ya?
Ada. Carbohydrate tu ke carbohydrate.
Ya?
Dia kalau awak suruh saya lari marathon sekarang 42 km, type 2 MI lah saya. Nanti saya berhenti.
Macam mana?
Severe sepsis dengan MI.
Severe sepsis.
Patient tak complain pun chest pain, tapi he is severe sepsis. Ada necrotizing fasciitis kat kaki tu. White cell 30, temperature hypothermia, HB 11. Dia lactate 8. ECG nampak ST elevation 23 AVF. Patient denied chest pain. Is not diabetic lah. He had a wound over the leg, then subsequently developed swelling, then developed bullous lesion. So that also not required a thrombolytic agent. Okay, you treat the sepsis, the ST elevation will resolve itself. Okay? Okay. The rest of it, you may need required thrombolytic agent. Okay, you may proceed.
Okay, thank you, Doctor. So from the ECG changes, we might locate where is the MI occurring. So for the anteroseptal lead is V1, V3, and extensive anterior V1, V6, and we might also have the posterior lead which is V7, V8. So we can locate the posterior MI more accurately. And for the if in the posterior MI in V1, V2, we can see ST depression and tall R wave. And for the anterolateral lead, which is 1, AVL, V5 and V6, and the inferior lead is lead 2, lead 3 and lead AVF. And V4R ni, I'm not quite sure.
Kalau ST, ni ada soalan. Kalau ST elevation kat 1 AVL sahaja, apa nama MI tu?
1 AVL saja. lateral MI.
High lateral MI, no?
High lateral.
Okay. Dr. Vila nak tanya soalan sabutan cepu emas ni. Siapa jawab dia dapat hadiah daripada Dr. Vila. Okay. Ada satu MI sebelum dia menunjukkan ST elevation di dalam dia punya lead, dia akan tunjuk changes dalam reciprocal dulu. MI mana tu?
Reciprocal.
1, 2, ada 10 saat je. 3,
Posterior
4,
ke?
5. Nanti saya nak tahu lead mana juga. 6, 7, 8.
Lateral. Okay.
Orang selalu miss MI ni kalau kita tak pick up. Tapi dia reciprocal dia dah tunjuk dah. Cuma kita tak tengok je reciprocal dia.
ETH.
Tik. Ya, dia tau. Tak ada siapa nak jawab.
Bukan posterior tu.
Posterior MI.
Posterior MI, you need the extra effort to do. This one in 12 lead ECG, you can see already.
Anterior MI.
Mesti nanti cari jawapan.
Tak ada jawapan. Okay.
Nanti doktor tak nak jawab. Nanti orang tak tahu pula.
Okay. So the other thing about the lead is, for example, lead V1, V2, which affect the septal area. It is usually the occluded artery is proximal left artery descending, left descending artery. V3, V4, the affected area anterior part, left anterior descending, and V5, V6 usually the distal LAD, left circumflex, or the right coronary artery. The next thing, so this is the place where we put the lead in the patient's chest, and we also sometimes we might put the posterior lead, which V7 or V8. But if patient have on the heart retro heart on heart the other side, so we put the lead also on the opposite side. So from this diagram, it is easier for us to memorize the lead and the affected region of the heart. Lead 1 and AVL, the lateral part of the heart. V5 and V6, the blue box, also the lateral part of the heart. And for the inferior MI, it is lead 2, 3 and AVF. And the anterior and septal is from V1 till V4 in the orange box and green box. So this is an example of ECG of patient having an MI. So from this ECG, we have to focus on the V2 until the V6 MI, V6 ST elevation. So, and also the lead 1 and lead AVL. Lead 1, AVL, V2, V6. We can see obviously the ST segment is elevated. So this is extensive anterolateral MI. And also from this ECG, we can see the reciprocal changes in lead 3 and lead AVF. The ST segment is depressed. So the next ECG, from this ECG, if we see the V1 until V4, it is quite obvious the ST elevation. So yang ni pun anteroseptal MI juga. So this ECG nak tunjuk lateral ST MI. So dia punya affected lead dia, lateral lead 1, lead AVL, lead V5 and lead V6 and V4 also lah, nampak dia punya ST tu elevated. And then the reciprocal ST depression kita boleh nampak dekat inferior leads. Lead 3 and lead AVF. We could see the ST depression, the reciprocal changes. So this is an example of inferior MI punya ECG. So kita tengok dekat inferior lead lah. Lead 2, lead 3 and AVF lead. There is ST elevation there at the inferior lead. Lepas tu kita tengok dekat AVL, boleh nampak dia punya reciprocal changes dia.
Kalau Alif tengok ECG ni lah Alif,
Ha.
do you doubt that there will somebody miss this ECG as inferior MI? Is it a clear cut picture dah MI dia? Typical sangat tak? Tengok lead 2 tu.
Rasa boleh nampak lah inferior MI. Sebab
Nampak
dekat
lah.
nama inferior lead dan ada reciprocal change kat AVL.
Kalau tanya Dr. Vila, the very obvious one in lead 3 only. I can't see in AVF.
Oh.
Alif dah bias ni sebab dah tahu dah tulis besar inferior MI kat atas.
Kalau saya buat quiz ECG ni tak ada siapa nak dapat inferior MI.
Saya agree dengan Dr. Vila lah. Lead 2 tu macam kalau dia tak tulis inferior MI kat atas tu awak tak cakap ST elevation.
Oh, ni kat lead 2 pun ni tak quite obvious juga kan.
Tak obvious.
Ya yang obvious dekat lead 3.
Lead 3 lah.
Soalan yang Dr. Vila tanya tadi, quiz tadi, dah jawab dah dalam soalan ni.
Oh ni lah inferior lah.
Tengok dia punya AVL.
Hmm.
Dia punya limb lead tak ada raise lagi. ST elevation is not a very obvious one. But the reciprocal already take place already. You see the ST depression with T inversion. So when patient come with a chest pain, if ECG not suggestive, concentrate on the reciprocal side.
Oh.
Inferior MI selalu dia akan place.
And satu lagi yang korang kena aware, in inferior MI, the ST elevation in lead 3 usually is more prominent than lead 2.
Oh, okay.
Dia kalau tiba-tiba lead 2 je ST elevation, lead 3 tak ada ST elevation, you kena start to retake your diagnosis lah. You really need to look for reciprocal, check balik your history and risk factor. Sebab very rarely lah lead 2 akan naik lebih tinggi daripada lead 3.
Oh, okay. Inferior MI fokus kat lead 3.
Inferior MI lead dia akan naik lebih tinggi daripada lead 3. That's one of the pictures lah.
Okay. Thank you for the info. So, from this slide just want to show what does reciprocal leads mean. So, contohnya AVL, the reciprocal image is actually just the mirror image lah of the lead. If this AVL, we can see the ST depression. So dia punya mirror image dia, ST elevation tu, the reciprocal changes lah in the ECG. So another ECG. This one, we can see at the lead 2. Lead 2, lead 3 and lead AVF at the inferior lead ST elevation. I think this strip ST elevation in lead 2 more obvious lah compared to the previous strip. And the reciprocal ST depression we can see at the AVL. So flowchart management of patient presenting with MI, ST elevation MI. First of all, the patient will come with chest pain or chest pain equivalent. So what we give the patient is firstly GTN, aspirin, clopidogrel, analgesia and
why they mention if no contraindication? So any patient MI ada ke group yang tak boleh bagi GTN ni?
GTN
MI kan bukan Dr. Vila boleh bagi untuk semua orang.
Ada yang tak boleh bagi.
Siapa orangnya?
Tak ingat inferior atau posterior MI lah.
Kenapa ya? Betul, jawapan betul. Kenapa?
Sebab because GTN will cause BP drop lah.
How it cause the BP drop?
GTN will cause vasodilation.
Where?
So
Where? Di mana dia akan dilate?
where?
Hmm.
Where?
Siapa nak tolong Alif ni? Kesian lah kawan-kawan hang ni tak nak tolong. Betul.
Right ventricle ke doktor?
Yeah?
Right ventricle ke?
Okay, very good. Any other place? Actually, it's a non-specific arterial and venule dilator. So, dia tak kisah tau. Dia tak akan choose favor to anyone. It will generally vasodilate both artery and venous.
Yes.
Inferior MI, kalau balik-balik tadi tu, dia is supplied by which artery?
Inferior MI. Inferior
Left coronary or right coronary?
Right coronary.
Very good. Okay, right coronary supply to which part of the heart mainly? Left heart or right heart?
Right coronary.
Supply which heart? Left heart or right heart?
Right lah kan?
Very good. Right heart. Memang soalannya soalan darjah 1.
Ah.
Tapi anak-anak murid aku.
Yeah.
Okay, right heart. Right heart preload dependent or afterload dependent?
Preload.
Very good. So preload, you need the volume or you need the pressure?
Preload.
The volume.
Good. Sama bagi GTN. Vasodilate. The amount of blood return to the heart will increase or decrease?
Decrease.
So you are basically causing more harm to the
Patient.
To the heart.
patient. Yes. So do not give GTN to inferior. Tapi Dr. Bila dah cakap jangan bagi. Tapi patient present BP 220, 120 dengan MI. Tak bagi?
Boleh lah bagi.
Boleh lah, at least 1 dose lah. Tapi kalau patient inferior MI, BP 80, 40 bagi GTN. So nampak dah, it's not the absolute contraindication lah. Cater according to your patient. And you must cautiously give lah. Okay, proceed.
Okay, baik. From this diagram, this flow will summarize what we will do to the patient. From the onset of chest pain, if it is less than 3 hours, so we might opt for primary PCI lah. Primary PCI. The primary PCI is preferred in high risk patients, and there is a contraindications of fibrinolytic therapy. And if it is after 3 hours, 3 to 12 hours, we can give primary PCI or fibrinolytics. But if, for example, we give fibrinolytics, after that, around 3 to 24 hours, we still can consider giving PCI to the patient. And if it is more than 12 hours after the onset of chest pain, we usually give medical therapy and anti-thrombotics.
Tapi kenapa ada Alif? Alif kenapa nampak dah dalam bracket ada primary PCI dengan warna merah tu? Benda tu. Kenapa dia nak buat juga kalau lebih daripada 12 jam tu?
This one, if the patient still ongoing ischemia or instable.
If beyond 12 hours, patient pain score masih 8. Patient unstable is opted for primary
PCI.
Okay, Dr. Bila nak tanya penting sangat. Okay, kat atas ni kan kita nak bagi GTN, kita nak bagi aspirin, kita nak bagi clopidogrel. Aspirin, how the mode of you going to give to the patient? Telan?
Yes.
Letak bawah lidah? Masuk dalam syringe? Suruh minum?
Minum lah doktor kan?
In what mode you're going to ask the patient to take? You have to give the in. Yeah?
Crush minum pelan.
Crushed aspirin. So please, bila order ubat tu, beritahu MA kita dengan clear order. I want a crushed aspirin 300 mg. No shortcut for it. It's a crush means memang kena tumbuk bagi pada patient. Clopidogrel, is in a tablet form. what is your choice of analgesia you would like to offer to the patient? NSAID, opioid, benzodiazepine. Nak bagi apa? Ya?
Opioid.
Saya tak dengar budak perempuan punya suara nah. Anak perempuan saya semua mana ni? Analgesia nak bagi apa?
Morphine kan doktor?
Ya?
So kita bagi morphine.
Selalu kita bagi morphine. Morphine falls into which group?
Opiates.
Oh, very good. Opioid, So we give opioid.
Opioid.
No NSAID, Never give NSAID in a patient ongoing MI. You tend to induce bleeding in that patient. Dia nak ambil STK, dia nak ambil thrombolytic agent pun is a risk for bleeding. You add additional dengan COX-2 inhibitor, which is NSAID. Okay, proceed.
Okay. So, the PCI, we want to reperfuse the heart as soon as possible. So, what is the aim of reperfusion? Reperfusion therapy is indicated in all patients with symptom of ischemia less than 12 hours and persistent ST segment elevation. Primary PCI is surely more superior to fibrinolysis for STEMI when performed in a timely manner at experienced centers.
Yang timely manner tu apa maksudnya sayang? Berapa jam ya?
Timely manner, primary PCI usually less than 3 hours after patient tu dapat chest pain.
3 hours
So,
Bukan 120.
120 minutes, 2 hours.
Oi.
Oh, that's like.
Okay.
Okay.
So are we a PCI center?
PCI center no.
Terdekat di mana?
Dekat HSB lah.
Okay, very good. Macam nak dapat MI, pergi Alustana, jangan dapat kat Snapton.
Okay. So, the thing we need to consider, time from symptom onset to FMC. FMC ni first medical contact, the first medical staff yang see the patient. Time to PCI, time from hospital arrival to wire crossing. This is called door to balloon time. And time to hospital fibrinolysis. Time from hospital arrival to administration of fibrinolytic DNT. And the contraindications of fibrinolytic therapy and the high risk patients. So what is the contraindications to fibrinolytic therapy? Most of the contraindication is related to bleeding. So the absolute contraindication is if the patient has risk of intracranial hemorrhage, the patient had history of intracranial bleed, had ischemic stroke within 3 months, had non-structural cerebral vascular lesion or had non-intracranial neoplasm, or if the patient had increased risk of bleeding, had active bleeding, significant head trauma within 3 months, or the patient had suspected aortic dissection. So the relative contraindication, if the patient had severe uncontrolled hypertension, ischemic stroke more than 3 months, chronic uncontrolled hypertension, and if the patient is currently using anticoagulant, or if the patient had recent major surgery less than 3 weeks, or the patient is pregnant or had exposure to streptokinase, latest exposure. So the high risk patient.
Okay. Sorry Alif, previous slide. Okay. Sekarang you orang aware dah kita ada NOAC, a new group of anticoagulant. Kalau dulu warfarin kan? Okay, sekarang kita ada NOAC kan?
Betul.
Okay. Ada dabigatran, semua yang tran-tran tu. So, katakan patient tu on dabigatran or any NOAC and came with a complaint of chest pain noted to have ST elevation. Do you want to thrombolyze or not the patient? Ataupun nak kita nak ambil INR baru tengok, baru kita decide? How?
Patient to patient.
Bagus jawapannya, tapi a little bit explanation. I very much appreciate and very happy to hear the answer, patient to patient. So, what is patient by patient? History apa yang penting dalam patient yang ambil Novak ini?
Patient had like bleeding tendency, ada macam bruise ke.
Tendency, he just have a chest pain but he's on regular Novak. One single history which is very important whether I'm going to decide boleh bagi sekarang.
Last time patient took the Noel.
Very good. Siapa jawab? Alif ya? When was the last time patient consumed the
Noel.
Novak? Okay, anything beyond 6 to 8 hours, patient is free to give he is allowable to ambil.
Streptokinase.
Yeah, any thrombolytic agent. Tapi kalau hang guna warfarin, you have to check patient's INR first. Okay? So kena tunggu untuk blood parameter. Untuk Novak tak perlu ya. Ataupun ada yang lagi satu, kalau tak silap Dr. Vila, dia ada reversible agent. Nama reversible agent dia Praxiban. Tak boleh abang Praxiban je lah. Nama generic dia I cannot mention it. It's very difficult for me. Idazuzam. Okay, you bagi itu, you boleh bagi your thrombolytic agent. Okay? Next.
Okay. Next. So what are considered as high risk patient? The patient that's having large infects, anterior infects, the patient current having hypotensive and in shock, insignificant arrhythmias, or the patient very old, post-revascularized patient and post-infarct angina. So what is the fibrinolytic therapy? It is when given within 2 hours from time of onset of symptom, it is called the golden hour of fibrinolytic therapy within 2 hours. It is most beneficial and has been shown able to avoid infarction and reduce mortality by 50%. So we have two choice of fibrinolytic agent. First one is streptokinase and the second one is fibrin specific agent. When fibrinolytic therapy is administered, the door to needle time should be less than 30 minutes. So
Apa
whenever
maksudnya? Sorry Alif, do you not understand the streptokinase and fibrin specific agent? Apa maksud dia? Streptokinase will fall to which group? Non-specific kan?
It is non-fibrin specific.
Dah ada jawapan dah. Okay. Apa maksudnya? Apa maksudnya?
It is antigenic and promote production of antibodies. Maksudnya kita takut patient ada allergies tu
Bagus. Okay. So lagi satu maksud non-fibrin specific tu maksudnya yang tadi tu fibrin specific kan? Fibrin specific agent like metalase, altiplase tu semua fibrin specific agent. Apa bezanya dengan STK ni?
Ada.
Maksudnya
STK tu ke longer time kan doktor? Compared to alterplase. Alterplase dia mode of action lagi cepat.
Okay, one is the mode of action. Actually, no, is the way we are administrating the medication. Okay, what is fibrin specific and non-fibrin specific delineate means? Streptokinase ni dia akan bagi kita the konsep pencairan darah ni whole over our generalized body.
Oh, not specific.
You understand? Not specific. So your tendency to get bleeding is higher in STK. However, in fibrin specific, dia attack clot je lah.
Faham. Target area.
Target area. So targeted area je. And another one more. Okay, let's say I have a patient who had a MI bulan 2 bagi STK. Dia MI balik bulan 6. Hari tu inferior, hari ni anterior MI. The pity thing, he developed the MI near SP jugalah. Dua-dua pun kat Sungai Petani. So, the second time he approached to our hospital, what agent would you like to provide to him? Nak bagi STK balik?
Fibrin lah.
Bagus je. Your previous slide, please.
No. Can I end this one?
Yeah, this right. Yeah, that's the side. You see, it's antigenic and promotes the production of antibody. So, nak bagi lagi, dia dah ada antibody. Katakan dia jenis yang senang dapat allergic, and it's a known case of asthma or eczema patient. The patient will go for anaphylaxis. Betul tak?
Okay.
You are inducing another allergic reaction in the patient. Chances lah. So, it is advised not to give STK in a patient who have received for the next 1 year period. Faham ya?
1 year.
Kalau hang bagi non-specific fibrin tu, tak apa. You can repeat, no harm. STK, it cannot be repeated next 1 year. Nah? Okay, next.
Okay. So as Dr. Villa said just now, streptokinase, it is non-fibrin specific and it is antigenic, promotes production of antibodies. So the regimen is 1.5 mega units in 100 ml of normal saline or 5% dextrose over 1 hour. So the other fibrinolytic agent is fibrin specific agent such as tenecteplase. It is cause more rapid reperfusion of the occluded artery than streptokinase and is given as single bolus dose. So it is weight based. The regimen is it is around 0.5 milligram per kg. So if the patient 60 kg, we give 30 mg. If the patient weight is 90 kg, we give around 45 to 50 mg. But following the administration of fibrin-specific agent, anticoagulant is recommended such as heparin or enoxaparin. Either one of these agents should be given for at least after 48 hours of completion fibrinolysis. So we gave the fibrinolytic agent to the patient, and how do we know the thing that we gave is a success? The first thing is from the symptom. The chest pain is resolved. The chest pain is decreasing. And then from the ECG, we can see the early return of the ST segment elevation. The height of ST elevation is reduced by at least 50%. So if it is reduced around 50%, the ST elevation, kita punya fibrinolytic tu success lah. And we can also see from the blood result also from the creatine kinase. And from the hemodynamic and electrical stability, daripada dia punya BP patient yang semakin improving tu, maksudnya reperfusion success. So macam mana pula kalau fail reperfusion? If it is fail, the patient will have continuing chest pain, persistent ST segment elevation, and the hemodynamic instability persists. So the treatment of choice for this patient is rescue PCI. So this is the type of PCI. The primary PCI, preferred reperfusion strategy for the patient. And we have also PCI post fibrinolysis. Maksudnya patient tu mula-mula dapat fibrinolysis, then after that kita bagi PCI pula. And then is facilitated PCI. Facilitated PCI ni plain PCI lah. And the other thing is routine angiography PCI after thrombolysis. So this is the flow chart lah. Macam mana, berapa lama masa yang kita perlukan sebelum untuk PCI. Basically dia punya total time dia around 120 minutes. If we macam hantar patient pergi ke PCI capable center with car or with ambulance, or patient come to the non-PCI center first pun, dia punya masa dia in total kita target around less than 20 minutes lah. Less than 120 minutes, sorry. What is the complications of ST elevation MI? After patient got ST elevation MI, patient might get arrhythmias, left ventricular dysfunction and shock, mechanical complication, right ventricular infarction, or patient might also got pericarditis lah. So the predictor single strongest predictor of mortality following ST elevation MI, we can use the kalau patient tu ada comorbidities, infection, pulmonary disease, diabetes, ni might aggravate heart failure lah. So we use the Phillips classification untuk for the prognosis post fibrinolysis ataupun post primary PCI. Kalau patient got Phillips class 1, no signs of left ventricle failure. So patient who got less mortality rate lah. Phillips class 2, dia ada S3 gallop, bivessel trachus and elevated JBP, higher risk of mortality. Lepas tu Phillips class 3, patient got acute pulmonary edema. Around 21 day, patient got 36% of mortality rate. And lastly, kalau patient got cardiogenic shock, within 21 day, 70% is the rate of the mortality rate lah. Around 30% je yang boleh survive post 21 day if the patient got cardiogenic shock. That's all my slide for today's CME.
Okay, ada siapa nak tanya soalan? Dr. Wila ada banyak soalan. Adik-adik sekalian nak tanya soalan?
Ada.
Ada. Alif, Dr. Wila bagi satu senario nah. I have a 50 years old Chinese gentleman presented with inferior.
Dr. Wila ada soalan dekat chat box.
Oh, tak perasan. Okay. Miss STK versus Miss MI definition. Okay, Khairul Anwar. Okay, apa maksud Miss STK ni? Tak sempat nak bagilah STK tu kan? Okay, Miss MI. Bila kita label dia pun sebagai Miss MI?
Miss MI ni maybe bila kita ambil ECG tu ada sign of old infarct.
Tak nak kata old infarct, recent infarct. Old
Recent
infarct punya changes
infarct.
dengan recent infarct punya changes lain ya.
Okay, recent.
So changes untuk mengatakan patient tengah mengalami MI tu adalah ST elevation dengan convex shape kan? Okay, yang menunjukkan patient dah mengalami infarction, development of which wave?
Q wave.
Q wave, okay. So pathological Q wave, Q wave ada normal, ada pathological ya. Okay, semakin deep Q wave tu menunjukkan ia adalah
Semakin pathological.
bukanlah, maksudnya dia dah berjadi, dah kejadian tu dah terjadi. Nasi tak jadi bubur. Tapi it's not only your ECG, no. First, you have to go back to the patient itself. Patient punya history is very important. Is the patient having ongoing chest pain? Dia kata, doktor saya ada sakit dada tapi dah 2 hari dah. Saya cuma nak main hari ni nak periksa je. Ataupun dia ada referral letter daripada GP suruh dia pergi klinik on hari 2 days ago but he came on 3rd day. Then we do a ECG on board. Kita buat masa tu juga, we noted to have ST elevation dia masih ada. About 1 box tapi Q wave in 2-3 area is very deep. The inversion. So that assume is a
Recent infarct.
recent MI with Miss STK. Maksud Miss STK ni patient punya jantung ataupun masa itu he's not a candidate for a reperfusion therapy. Mengapa kita nak bagi reperfusion therapy ni? Kita nak selamatkan tempat yang belum kena infarct. Faham tak?
Sel yang masih hidup.
Yes, your Q wave indicates it's already infarcted area. No role you're giving a fibrinolytic agent to dilute the clot in order to reperfuse the area. Tak ada lagi dah fungsi dia. Itu maksudnya. Anwar, am I clear to you?
Come.
Clear, Anwar? You can use the word recent MI, Miss STK, Miss MI tak ada lah. Recent MI with the Miss STK. Itu the best impression you can give to the patient. Okay dah, Anwar? Okay, any question? Boleh Dr. Wila pula tanya, boleh nah?
Boleh.
Okay, I have a 50 years old Chinese gentleman presented with the inferior MI, patient in red zone, ongoing STK. Okay, STK kan kita akan pancur dalam 2 infusion pump kan, 50-50, the syringe, 50-50 kan. So, once he complete the first 50cc syringe, noted patient develop rashes, urticaria in lesion, generalized in nature, associated with itchiness. Sekarang Dr. Solang punya Dr. Vila, nak kita sambung STK or tak nak?
Boleh cover.
Boleh cover. Alif nak cover dengan apa, Alif? Blanket.
Hydrocor.
Cover dengan hydrocor. Okay, patient develop rongkai juga. You want to cover? Hydrocor lagi? Anyone have any other answer? So hydrocor per se enough?
Not oxygenation juga sekali.
Okay, so what are you dealing now? What condition are you dealing now?
Allergy reaction secondary to streptokinin.
Very good. Okay.
Tapi still not in anaphylactic shock kan.
Oh, tapi hang tak tanya pun BP patient macam mana?
BP apa?
Okay lah, BP stable lah. Doktor tak nak bagi kes yang teruk-teruk lah. BP stable. 120, 80. Comel. So you want to give hydrocor, piriton, lepas tu sambung balik. Okay, how about the others? Ni senario yang real lah. Dr. Vila encountered lah. Any other taker?
Adrenaline sambung STK dekat checkbox.
Adrenaline. Anwar patient tak shock. You only give adrenaline if the patient develop anaphylactic
Shock.
Patient not in or there is other diagnosis for anaphylactic shock juga. He does not fulfill the anaphylactic shock criteria. It's just allergic reaction. Okay, kalau tak ada jawapan, Dr. Vila share Dr. Vila punya experience dah. Okay, what I did, I approached back to the patient. So I asked the patient how his chest pain at the moment. So he said his chest pain resolved. Pain score 0. And I did the ECG. ST elevation dia resolved completely. Completely tau. Yang 2-3 AVF tu tak ada lah elevation dah. Just by giving the first half 50cc tu. So, Dr. Vila decide not to give the second STK. Sebab clinically, dia dah achieve reperfusion dengan hanya
First boleh.
First 50 sahaja. Tapi ni case by case tau. Bukan semua patient hang boleh buat macam tu. Patient tak dah resolve, hemodynamically stable. So I don't want to unnecessarily want to put him for the next allergic. Takut-takut dapat anaphylactic. So I don't want to put him at the risk. So I stop the STK. I closely monitor, admit to CCU. Faham tak? So do not be very strict. When you give STK or any fibrinolytic agent, please be beside patient. Because the whatever clinical pathology or pathogenesis going to take place is extremely dynamic. Kadang-kadang tak sempat nak tengok patient. Tengok-tengok bunyi cardiac monitor yang tengah bising. Tengok patient tengah VT. So you kena ada sebelah patient to provide the shock as soon as possible. Understood?
Faham.
Okay. Thank you. Good presentation, Alif.
Thank you, Dr. Vila,
Thank you.
for the experience sharing.
Okay, we can proceed with the next one.